Dr. Brink, we invited questions from the public, questions for Dr. Brink. We had more than 100 in a very short space of time, so everyone's got a lot of questions for you. Now, we've picked out just a few here to put to you. And let's start with a few that all relate to our exit strategy, our exit framework. So first of all, when will we be able to add more bubbles?
So thank you, Rob. We're in a really good place, as you know. It's the 14th today, and we're day 14 of no new infections. So a really positive place to be in. So we are looking to see how we can move and add more bubbles. Our bubble concept's been extremely popular, as I'm sure you know. And what we're looking to do is over the next week make some announcements about how we can increase our bubble size. So we want to keep the concept of bubbles, but gradually increase them until eventually we end up in a bailiwick bubble, which is phase 5 of our exit plan. So yes, we're looking at increasing it. Announcements should be available shortly over the next week or so.
Okay. Another question that has come in from more than one person is about weddings. So this particular person says, I'm trying to make a decision about my wedding, which is due to take place on the 4th of July. I understand no one has all the answers and the situation could change either way as testing results come through, but she says she wanted to get a further opinion.
So this is something I've had a lot of queries about, and I can quite understand. A wedding is so important and you want it to be a lovely day. So from our perspective, again, it's something we're looking at really closely, and we're specifically looking at weddings. I've had a lot of messages through the inbox saying they'd like more information on weddings. People want to know what's going on. So again, over the next week, we will be making announcements specifically relating to weddings. We're doing some calculations at the moment, looking at size, looking at public health risk and so on, but we will be giving some specific information over the next week. So if you could just bear with me for the moment, it's very much on our agenda.
Okay, another question that we hear time and again, this person asks, if we've all been socially distancing for almost 6 weeks, quarantining for 14 days following any overseas travel, washing our hands and all of that, why is there still a risk of infection? In other words, surely there's nobody left infected going about their business infecting anyone else.
That's a really great question, and again, it's something I've been asked quite a lot. So what we're looking at is, as we get more and more days that are virus-free, we're looking at a risk that's dramatically reducing, but we're not at a zero risk. So within the community, there might be some undiagnosed infections. We have encouraged people to come forward. We've got our broadened diagnostic criteria, so much broader, for example, in England, where we include things like flu-like illnesses, sore throats, loss of sense of smell, loss of sense of taste, in addition to the fever, cough, and shortness of breath. So we've had a far broader diagnostic criteria, but there might still be people in the community that have yet to have their infection diagnosed. And of course, there can be asymptomatic people. So these are people that have no symptoms at all. So the more days of no new infections we have, the more likely it is that we're moving towards elimination of the virus from our island population, but we're not there yet. So we need to be sure that we've diagnosed and quarantined and contact traced every single case. And evidence globally suggests that if you're complacent and release too early, what you will see is a resurgence of infection. So we really don't want to lose all of that hard work that we've done to date. So we're moving in the right direction, but we need to be cautious, we mustn't be complacent, and most of all, we mustn't lose those gains that we've achieved.
Another area where we've had a number of questions is about care homes. Which we've described in some ways as our front line. So one of the questions that's come in, Dr. Brink, is how many of the remaining infected cases of COVID-19 are in care homes?
So in fact, we're in a really good position now with regard to care homes. So with regard to the staff members, we have no staff members that are now currently infected. So all of the staff members have resolved their infection. We have 2 residents that are still positive and have been positive for quite a considerable amount of time. That's not uncommon in older people because they might take longer to resolve the infection. And here I'd like to remind viewers that we have a different process to calling people recovered. So we don't rely on people's symptoms resolving, is we actually test people to ensure that they are recovered and they've actually cleared the virus. So we have 2 people whose clearance has been more delayed, probably related to their age.
Another question on care homes is, do you have any idea when it might be possible to visit family in care homes, even if that's socially distancing 2 meters away? This person says, I haven't seen my dad, who has severe dementia, in almost 2 months now, and I'm worried that he is so frail I won't see him again.
I think that's a really difficult question, and I think it's been one of the most difficult things that I've dealt with over the course of this COVID-19 pandemic. Not seeing family, close family members is heartbreaking. There's no other way to describe it. I think what I'd like to highlight here is that infection in the care homes, both in Guernsey and in other cases of the world, has had very serious consequences for those residents, and those infections have been brought into the care homes. So inadvertently, of course, but nevertheless brought in by either staff members or visitors. So really important from that perspective when we now consider what we do about that. So we're looking at visitors. We need to be careful that we don't inadvertently cause more cases within the care home situation. Having said that, this is something we are carefully looking at, and we are going to evaluate it in the weeks to come as to when we think it's safe for care home visits to restart. So something that we're actively considering, but I wouldn't want to give a precise date on that because we need to be sure that any visiting is as safe as we can make it.
So another topic where we've had a number of questions is from people who are shielding, wondering what they should do. And the first person on this asks, they say, I am shielding due to severe heart failure. I have not joined a bubble, but I am really struggling with being isolated. What are the guidelines around shielding, please? And what will happen when people can go back to work? Will I need to continue to shield?
So to answer that question specifically, can I just remind everyone what shielding is? So people who are shielding for a particular medical condition. So there might be a transplant, they might have had a transplant, they might be receiving treatment for a specific type of cancer. So they'll be shielding for a very specific reason. So with shielding, people will be not only will be isolating within their house, but they'll be having very limited contact with people. So the person who wrote the question is absolutely right. It can be very lonely and very isolating and not good for a person's general mental health and well-being. So we need to also ask ourselves as to why people are shielding. So they're shielding for their own personal protection. So linked to that comes a degree of personal choice. So what I would recommend under these circumstances is people consider what their condition is, understand that their condition makes them at greater risk to the serious consequences of COVID-19, perhaps have a discussion with a healthcare professional providing clinical care for them as to what the risks are for them, both with regard to going back out into the community, bubbling up with another household, or indeed going back to work. So I don't think this is a one-size-fits-all. I think there needs to be an element of personal choice here, but I think people should be cognizant of the fact that they may indeed be at risk of more serious infection or more serious consequences of infection if they do get COVID-19, and have that discussion with their healthcare professional.
And it isn't just necessarily older people who will be shielding, as we know. And the next question comes from someone who says, my daughter has not stepped out of the house since the 21st of March. She has cystic fibrosis. Is it possible to take her out for a drive? Will it be safe enough now that there have been no new cases for some time?
So I'd say absolutely it's safe enough to take her out for a drive. And I'd actually encourage it for your daughter's general well-being. So again, it must be extremely frustrating, very lonely and isolating for your daughter. So taking her out for a drive in the car, getting some fresh air, keep the window of the car open, nice and well ventilated. But from that perspective, I think it's absolutely okay to take your daughter out for a drive. In fact, I would actively encourage it because I think it'll be good for her general well-being.
Dr. Brink, another topic where we always get questions, you always get questions, is on testing, which can cover a lot of things and mean different things to different people. But let's start with this question, which has come into us, and we've seen it coming up in other places too. This person asks, can you give an answer as to why the positive testing results are taking a few days to reach the public? This person says, correct figures should be updated as soon as the tests are complete. I feel that you are withholding the correct information for far too long, and the general public will not take it seriously enough if we're continuously told no new positive tests when this person says they know there have been a few positive tests.
Well, I have to say I'm really concerned about where this person is getting their information from. And I think I would encourage people to look at gov.gg because the accurate information is there. However, this person clearly has got their information from a source, and so I will explain what I think they're concerned about. So what we publish every day are the new cases of COVID-19, so the new positives. So that's really important because these are newly diagnosed infections. But as I've always said, when we look at our cases, is we don't just rely on clinical recovery. So people that are diagnosed positive, we don't just rely on clinical recovery. We test them at the end of 14 days, or sometimes later if they're still symptomatic. Some people, the symptoms can drag on for quite some weeks. What happens when we test people at 14 days? Some of those people are still positive, in which case we will keep them in isolation and retest them at a later stage. So really important, what we put up on our website every day are the newly diagnosed positives. And we will be testing people after they've been diagnosed as positive, usually on day 14, but sometimes later than that. And those people might still well be positive. So when we do our daily run, yes, we do get some positive results, but these are from active cases that we know about that we're testing to see if they resolve the infection. We test at the end to make sure that no one who is infectious goes back out into the community. And that is one of the reasons why we've been so successful in squashing our curve. So again, the information that we've provided has always been open and transparent. I've said from the beginning that Guernsey the bailiwick owns this data. It doesn't belong to any sector, and we've always communicated this in a very open and transparent way. So I hope that explanation suffices to explain what the reason for that is, but also to quash any conspiracy theories. There's simply no conspiracy here.
Another question that's come in relating to testing is, this person says, with several other countries offering chargeable, in quotes, testing on arrival facilities to avoid a compulsory isolation period for uninfected people coming in, will Guernsey be offering a similar service? If a person can confirm they're not infected, even at their own cost, there should be no need for them to self-isolate.
So I would absolutely disagree with that, and the reason being is that the incubation period of the virus is anything from 2 to 14 days. So you could come in, be tested and be negative, but actually be positive indeed that afternoon or the following day. So testing is only a single snapshot, a single point in time. And if you wanted to be sure, you'd have to test up to 14 days. So a single test will only tell you that the person is not infected on that day. It won't tell you what's going to happen the next day or indeed the day after. And so that's really important that we maintain that 14-day quarantine. If we looked what happened in the early days, so in March going on into early April, most of our infections were acquired through travel. And the moment we restricted travel and put the 2-week quarantine for all returning travellers, we saw a dramatic reduction in infections attributed to travel. So a single point of test is not going to provide us with security. We need to keep that 14 days quarantine.
And one very last question. Thank you for your time today. A very last question on testing. This person says, I would like Dr. Brink to cover antibody testing. Is this starting up anytime soon? Healthcare staff, this person says they work in healthcare, have been waiting 2 months for this.
Right. So I think I would encourage all healthcare staff who want to discuss antibody testing to contact us, because we certainly would like to enter that dialogue. But you've got to ask what you're testing for. So I think there are a number of situations where I would envisage antibody testing coming in. If you're talking about testing staff to see they're immune, I would be very concerned about relying on the presence of antibodies to say a staff member was immune to the virus. So the antibodies that we test, we don't know what type of antibody they're measuring, or indeed if they're what we call neutralizing antibodies, so would prevent someone from getting infected. So if someone was antibody positive and was a staff member, we would still be wanting them to take all the precautions, wear PPE and so on. As time progresses, we might, towards the end of the year, look at what our rates of infection are in the population. We suspect they're very low, so our seroprevalence in the population is going to be way under 5%, probably under 2%. So we think from our perspective, doing a population-based seroprevalence survey would be too early, and indeed we need to focus our resources on what we're going to get the most population-based benefit for, which is why we've launched our bailiwick extended testing strategy, which is focusing on the moment on the direct detection of the virus, and we want to rapidly increase the number of cases we test up to about 400 a day. So we're looking at really ramping up our direct viral testing. But linked to that, I can also think of specific clinical situations where you might want antibody testing as well. So antibody testing might be helpful in people who you think have had COVID and actually have got rid of the virus but still have some symptoms that you think could be COVID related. So some of the symptoms in the latter part of a COVID infection can in fact be caused by the body's immune system. So in those situations, antibody testing may indeed be useful. So that brings me on to what type of antibody tests. So there are various tests being looked at. One are the lateral flow tests, which are the cassette tests, the finger prick, so a bit like a pregnancy test. And those have had some problems. They are being used, but from our perspective, we would rather use the well-based assays, so the 96 well-based assays. We have purchased some of those, and we're looking at standardizing those. But I think our focus on the moment is on enhancing our direct viral detection, but also alongside that developing antibody testing. So I would envisage that would be available over the next month.
Just before we leave you, Dr. Brink, apparently you have had a question sent in directly to you that you're keen to answer.
Yes, so this is a question from Oscar, who drew me this lovely picture. So thank you very much for the picture, Oscar. And Oscar's granny is very special because Oscar's granny is a public health nurse. So she's very special and she's a member of the team and she's been working on COVID-19 with us. But Oscar had two things. He wants me to tell Mrs. Rooney at St. Martin's School that she's very cool. So obviously, Mrs. Rooney, you're highly rated by the children in your class. But Oscar also wanted to ask about playtime when he went back to school, and particularly if he could, and I quote, play toilet flush tag. Now, I have no idea what toilet flush tag is, but what I do want to say to Oscar is that when you do go back to school, things might be a little different, and so Mrs. Rooney might be asking you to do things in a slightly different way. So I'd ask you to listen to Mrs. Rooney and only play the games that Mrs. Rooney says are a good idea to play.
Toilet flush tag sounds like the kind of game Mrs. Rooney would never want Oscar to play, I suspect.
Well, I have no idea. Mrs. Rooney can probably tell us that.
Thank you very much, Dr. Brink.
You're welcome.